Assalamu alaikum everyone. My name is Samhar Alouch, third year medical student, and today I'm going to explain this very important lecture to you guys, which is titled Hemodynamics II. I know this lecture is included in your midterm, and so I try to include every single thing the doctor said in his lecture with a very simplified way. So the slides, I made my own slides, and it's only 24 slides, and not all of them is actual content. So maybe only 18 of them is actual content. So please study these 18 slides for your exam because it contains everything in a very simplified way. And this is the continuation of Hemodynamics 1, which is my friend Khalid Najjar explained to you. And so just to understand my way of explaining, I have this slides, but I usually explain on this white page, draw and explain everything, and then I go back to the slides and correlate whatever I said there with the slides. And so without any further ado, let's get started. So the first concept in this lecture is vascular compliance. And so compliance in Arabic is al-muruna for any Arabic speakers. And so it is how much easy for the blood vessels to expand, okay? And so assuming we have this blood vessel and we are putting blood in it, okay? We are pushing blood in it. If it has high compliance, then it is easy for it to expand. And so this blood vessel will become like this, and it will contain very high blood volume. However, if it has a low compliance, then even if we put blood in it, it will be stiff and it will not expand. And so this blood will come back, and so we will have very low blood volume. And so compliance is how much easy for the blood vessels to expand and contain more blood. So vascular compliance is how easy to fill a blood vessel, like how easy to put the blood in it, because it's related to how much the blood vessels will expand. Or in a scientific way, it's the ability of blood vessel to expand and contract passively. And so for the last time, compliance is how much easy for a blood vessel to expand and contain more blood, or it's how easy to fill this blood vessel with blood. And so if we have a blood vessel with a low compliance, when we put a blood in it, since it has low compliance, it will be stiff and the blood will revert back. But if it has a very high compliance, the blood vessel will be big, like it will expand, and so it will contain very high blood volume. And so that's what compliance means. Just a sec. Okay, so that's what compliance means. And I put this in gray because the doctor said, don't memorize it, but compliance is related to blood volume over the pressure. Okay, the difference in pressure, but don't memorize it. Just know that it's related to blood volume and pressure, and we'll explain that more later. And so now we have two types of compliance. Okay, just a sec. So as I said, compliance is how much easy for blood vessels to expand and contain more blood, or how much easy for to fill a blood vessel. And so compliance is related to two things, and so we have two types. First, let's review some of the histo you took. We have a blood vessel, and around the blood vessel there is collagen and there is elastin. And these two things are a connective tissue that are making the blood vessel expansion and let's say expansion and contraction easier or harder. So they are the things or the connective tissue that's play a role in the, let's say, compliance. And so we have two types of compliance, okay? We have static compliance and dynamic compliance. Okay, so static compliance is the compliance that it's permanent all the time. So it's a compliance that presents all the time, and it's related to things that also present all the time. It's a compliance that if we lost, we can't get it back again, because it's related to things if we lost, we can't get back again. And so static compliance is related to two things. They are collagen and elastin. And so since it's related to these things, once we have calcification of a blood vessel or loss of collagen or loss of connective tissue, we can't restore them back. And so this static compliance, we can't restore it back. Okay, so let's go here. Static compliance is a physical property of a blood vessel that depends on the amount and properties of two connective tissue. They are elastin and collagen. Okay, so for the last time, static compliance, it's a permanent compliance that present all the time, because it's related to two things that's present all the time, elastin and collagen. And once we lose this connective tissues, this compliance will be affected permanently. It won't change again. We can't revert it back to how it was. One last note that elastin is not something that making compliance more. It's actually something that decrease compliance. Because if you remember, you took that a blood vessel that has elastic fibers can recall very easily, because elastic fibers have one feature that once you fill the blood vessel, it will expand, but then it will recall with the same power of expansion. And so this recorrelation is similar to stiffness. And so it will make the blood vessel narrower. And so we can't put blood in it, and which will mean that the compliance decreased. And so the vessels with less elastic connective tissue have more static compliance. So for the last time, static compliance, it's a permanent compliance that's related to permanent stuff like collagen and elastin. Once we lose this static permanent compliance, we lost it forever. We can't revert back to normal. And one last note, that elastin is something that decreased compliance because it increased the elastic recoilation. Now, let's talk about the second type of compliance, which is dynamic compliance. And from its name, it's dynamic, means that it's changeable. So you took that a blood vessel is innervated by sympathetic nervous system. And sympathetic nervous system is, when we stimulate it, it will increase the muscular tone of the blood vessel, and it will cause vasoconstriction. And once we have vasoconstriction, the lumen will be decreased and the blood vessel will be narrower. Narrower means that we have low compliance, right? And so increasing the sympathetic stimulation of a blood vessel will cause vasoconstriction, and this vasoconstriction will make the blood vessel narrower, and having a narrow blood vessel means that it has very low compliance. But this very low compliance is related to the sympathetic nervous system. So once we remove this sympathetic stimulation, we will not have this vasoconstriction anymore, and the compliance will reverts back to normal, and we will have our normal usual compliance. And that's exactly what dynamic compliance means. Dynamic compliance is a compliance that it can be changeable over time through some phenomena like sympathetic stimulation, let's say. And so dynamic compliance, it's a compliance that can be changeable over time, and it's mostly related to sympathetic stimulation. Once we have sympathetic stimulation, this compliance will decrease, but once we remove this sympathetic stimulation, the compliance will revert back to normal. So I hope you guys understood this slide well. Now let's talk about what is this compliance made of. So as I said in the slide before, compliance is the difference in volume over the difference of blood pressure. But I don't want you to memorize these things, but I just want you to remember that compliance is related to blood volume and to the blood pressure. How? Okay, so now we have a blood vessel, okay? And I'm telling you that we have a very high pressure putting it into this blood vessel. And once we have a high blood pressure putting into a blood vessel, this means one thing, that we are putting so many blood volume into this blood vessel. And so if this blood vessel have a very high compliance, this blood vessel will expand. And once it expands, this means that it has a very high blood volume. However, if it has a low compliance and we are putting some pressure and so much pressure and so much blood filling into it, but it has a low compliance, it will be stiff and it will not allow the blood to enter, and the blood will revert back and we will have low blood volume. So what does this all mean? This means normally, if we have a normal blood vessel, when we increase the pressure or when we increase the filling, normally we will have high blood volume, or we will increase the blood volume. So if we made a graph and this is pressure and this is volume, once we increase the pressure, we will increase the volume, and it should be like this, okay? So once we increase the pressure or the filling, we will increase the volume. That's in normal circumstances. But since we have compliance of the blood vessel, if we have high compliance, the blood vessel will be big and it will contain more blood volume. And so once we increase the pressure with a very high compliant blood vessel, we will have way much higher blood volume. So look here in this blood pressure, we have, let's say, blood pressure of 20, blood volume of 50. But since we have high compliance, this 20 blood pressure will make us having, let's say, 100 blood volume. So that's the first thing about compliance. Compliance very high compliance will make us having higher blood volume on a specific blood pressure. Now, this is the first thing. Now, the second thing, if we have pressure and volume, and we have low compliance, and we are putting blood with the pressure into the blood vessel, the blood will revert back. It can't enter the blood vessel, and this means that there will be a low blood volume. And so having low compliance will make us have lower blood volume on a specific blood pressure. Okay, it will decrease the blood volume. So what does this all mean? It means that compliance is related to the slope of this graph. So we have pressure over blood volume, this pressure over blood volume. When we have high compliance, this will increase the slope. It will make it like this. When we have low compliance, it will decrease the slope and it will decrease it like this. And so in this graph, you must know that if we have a very high blood volume and a specific blood pressure, this means that we have a very high compliance. On the other hand, if we have a very low blood volume on a specific blood pressure, this means that we have low compliance. And why is that important? Because the questions are like this. They give you two graphs, 1 and 2, and they ask you how to revert from 1 into 2. And the answer is by increasing compliance. And how do we revert from 2 to 1? And that's by decreasing compliance. So I hope this was clear. I know I'm rushing it, but I want to finish with the least amount of minutes so you guys and don't have a very big lecture like 2 hours or something. So this is the graph. We have pressure and volume. And as you see, we have arteries and veins. Arteries have elastin. And what do we say about elastin? That it causes recoilation. And since it has recoilation or it causes recoilation, this means one thing, that it will have low compliance. But veins doesn't have elastin, and so they will have high compliance. So this is something you must memorize. Arteries have low compliance. Veins has high compliance, okay? And that can be seen at this graph. Arteries has low compliance, and that's why at specific blood pressure, we will have a very low volume, and that's why the slope here is very low. However, veins have a very high compliance, which means that at specific blood pressure, we will have a very, very high blood volume. And so please understand this graph. When we have low volume, at specific pressure, we have low compliance. When we have high volume at specific blood pressure, we have high compliance. Clear? I hope this was clear. So compliance is indicated by the slope of the curve. When we have high slope, we have high compliance. So once the slope is big, we have a high compliance. Now, one important note about the graph of the veins, please look. Here at the beginning, let's say this is the blood pressure from 0 to 100. Here, from 0 to 20, you can see how much the blood volume is increasing dramatically. Like from 5 to 10, we have, look, to this big increase, okay? But here, from 20 to 100, look to the increase of blood volume. It's not much. So we must notice two things. At low blood pressure, venous compliance is very high, okay? At low blood pressure, like venous compliance is very high all the time, okay? Venous compliance is all the time high. But at low blood pressure, it is very, very high. And at high blood pressure, the compliance decreases a little bit, okay? And so please memorize this thing. At low blood pressure, the venous compliance is very high. At high blood pressure, when we have very high blood pressure, we have the compliance decrease. And that's mostly because if we have a blood vessel, the vein, and we are putting blood pressure in it, it will start filling at the beginning. And so its compliance is big. At some point, it will be full. It will be fully expanded. And so even if we put very high blood pressure, the compliance reach its max. It's expanded maximum. And so it can't expand much anymore. And so that's why the compliance decrease. So for the last time, at low blood pressure, we have a high venous compliance. At high blood pressure, the compliance decrease because it reached its maximum expansion. And for arteries, it has low compliance in all the time. Low blood pressure, very extreme high blood pressure, it's all the time, it's low compliance. Now this picture explains the arteries and vein. Arteries is similar to balloon. They have the elastic recoil, and so filling them is kind of tough. They will expand, but it's kind of tough. For veins, they are like plastic bags. Just put the volume in them and they will just expand. There is no elastic recoil or nothing like that. I hope this was clear. So now let's talk about change in compliance. As I said, we have here the pressure and here the volume. And so this has a very big slope. This means that it has a very big compliance, right? Now, what will happen if I decrease the compliance? it will become like this, right? The slope will decrease. And so this would revert to be this or this. يعني خلاص, the compliance decreased, the slope will decrease. And so the amount of blood volume at specific blood pressure, it will decrease. يعني here at 50 blood pressure, we used to have 100. If we decrease the compliance, it will be 80. If we decrease it more, we will have 60. If we decrease it more, we will have 40. And so once we decrease the compliance, the blood volume will decrease with it, and the slope will decrease, and the whole graph will go down, shift down a little bit. Okay? And so when compliance decrease, the volume will decreases too. And that's on the graph, but in real life, if we put blood here and the compliance is low, it will be stiff, and so the blood can't enter and we will have low blood volume. Okay, so that's on graph, this is in real life. Okay, now why would the compliance decrease? What are the things that will make compliance decrease? Now for dynamic compliance, we said is the sympathetic stimulation that will cause vasoconstriction. If we cause sympathetic stimulation, vasoconstriction will happen, and so the dynamic compliance will decrease because it will become narrower. Now for static compliance, things that stay for lives, first thing is age, because when we age, calcification will happen, collagen will decrease, and so the static compliance will decrease, and the blood vessel will be more stiff. And some arterial diseases like atherosclerosis, اللي هو تصلب الشرايين, and from its name, تصلب الشرايين, atherosclerosis, the artery will be stiff, and so the static compliance of it will decrease. And so these are the things that will decrease the compliance, and once we decrease the compliance, the slope will decrease, the blood volume will decrease, everything will decrease. Okay, now that's finished one concept. Now we have another concept. We have something called capacitance vessels, and these capacitance vessels are veins. They are the vessels that store the blood all the time. And so this is, wait, just a second. Yes. Now this is our body, okay? And in our body, we have arteries and we have veins. Okay. Now, arteries are stiff and they are always contracting and pulsatile to move the blood into the whole body. And so they are not acting as a reservoir of the blood. The blood doesn't stay in them. It's just moving all the time. And so arteries contain around 20% of our blood, around that. And veins contain the other 80%. Okay. Veins have a very high compliance, and so they are very expanding, and so they contain the blood volume all the time, and so they act as a reservoir. The blood is in them all the time in our body. It's just there, okay, staying all the time. And so the capacitance vessels are the veins. So veins act as a reservoir for blood because of their high compliance. It's very big that the blood vessel or the vein itself is very expanding, that the blood is fully in it all the time, okay? And it's 20 to 25 times more compliant than arteries. And this reservoir is used to increase venous return and cardiac output. Now, what does that mean? So now this is our heart. And here we have the right atrium, okay? This is the right atrium. And let's say this is the left ventricle, and left ventricle is related to arteries, right? The blood will move through arteries to capillaries, and then from capillaries to veins, and then from veins to the right atrium once again, okay? And so, as I said, veins act as a reservoir all the time. So they have 80% of our blood, and it's just there, staying all the time, okay? Now, assuming I started exercising and my heart started beating, and I need more blood into my extremities, like muscles, what will happen? Now, the sympathetic stimulation will increase, and it will go to the veins. It will cause veins contraction. And we said veins has very big compliance that can make it very expanded and has very high blood volume. Now assume that we caused veins contraction. So now this is full and we contracted it. The blood in it will go up. So this is a big vein that contains very big blood volume. And if we contracted it, the blood will be pushed, and where it will be pushed to the right atrium, to the heart, and this will increase the cardiac output and the venous return. Venous return means the blood returning to the heart. Cardiac output is the amount of blood going out of the heart. So for the last time, veins act as a reservoir for the blood. Most of the blood is in it because of its very high compliance. And if we needed more blood, sympathetic stimulation will increase. It will increase the tone of the muscles of the veins. It will cause vasoconstriction of the veins. blood will be pushed into the right atrium, which will increase venous return, and in so it will increase cardiac output. And this explained here in this weird, let's say, graph. I hate this graph. Just understand it, don't memorize it. We have a vein that has a very high blood volume. We increase the sympathetic stimulation, it will contract, it will go to the heart, so increased venous return, increased cardiac output. And why veins? Because veins are the capacitance vessels, because they have very high compliance and they contain most of the blood volume in our body. Okay, now we will talk about something else called central venous pressure. Now, what is venous without central? Okay, what is venous pressure? It's the pressure of blood in the veins, because it's venous pressure. So venous pressure is the average blood pressure of the venous compartment. So in all the veins in our body, the average of the pressure of them is the venous pressure. Now, what is central venous pressure? Venous pressure is the whole body. Central means that we are targeting specific place in the body. And central venous pressure is the thoracic vena cava near the right atrium. So this is the heart. This is the right atrium. There is thoracic vena cava here. And so central venous pressure is the pressure of the thoracic vena cava only. Okay? So the pressure of this only. And so changes in the central venous pressure occur either to do two things. One of them is stroke volume, and the other one is compliance. Stroke volume is similar to cardiac output. Compliance is what we have been explaining the whole time. خلاص, we know by now that this graph, when we decrease the compliance, it will decrease down like this. Okay? خلاص, I don't want to explain this anymore. Now we have specific, these things, please memorize them. I got one of them wrong in the final just because I decided to skip this slide and خلاص I understand it without focusing on them each one. So please focus on them. Now we will explain them one by one. So as I said, we have this heart, we have right atrium, and we have the central venous pressure, which is the thoracic vena cava. We said that thoracic vena cava affected by two things: stroke volume, اللي هو amount of blood getting out of the heart, and the other one is the compliance, like how much compliant this vein is. So now let's talk about these cases. Decrease in cardiac output, like in left ventricular heart failure, will lead to blood backing into venous circulation, increase the central venous pressure. By the way, now we are explaining cases that increase central venous pressure, اللي هو the pressure in this vein. And how does it increase? By increasing the amount of blood in it, by increasing its pressure, by decreasing stroke volume. Several cases, we will talk about them now. The first case is once we have left ventricular heart failure. Heart failure means that the left ventricle can't push blood anymore. Okay, now this blood can't be pushed. Where it will go? It will go back to the lungs. Then from the lungs, it will back up. حيصير accumulation in the right ventricle, and so it will accumulate in the right atrium. At the end, it will accumulate in the thoracic vena cava, increasing its pressure because we are increasing the blood volume in it. So that's the first case. Okay, understand it, please. We have a heart. It can't pump blood anymore, so the blood will accumulate in it till it will reach the right atrium. Then from the right atrium, it will accumulate in the thoracic vena cava. And since it accumulates in the thoracic vena cava, it will increase its pressure, which will increase the central venous pressure. This is the first case. Okay, they will literally ask you about this case in the MCQ, and you just need to choose. Increase in central venous pressure. Now the other one is increasing blood volume. So خلاص, in our body, we drink a lot of water. We have drinking so many fluid that will increase the blood volume. And since we are increasing the blood volume, this will increase the blood volume in the thoracic vena cava, increasing its pressure. That's the second case. Now, the third case is venous constriction. Okay, now we have this thoracic vena cava with its muscular parts. And once we put sympathetic stimulation in it, it will vasoconstrict. And once we have vasoconstriction, this means that we increase the pressure of the thoracic vena cava, which means that we increase the central venous pressure. Okay, venous constriction increase the central venous pressure. This is the first three cases. Changing position from standing to supine. What does that mean? Now I'm standing, and so because of gravity, most of the blood is in the leg veins. Okay, Now I lay supine. The gravity will cause the blood to accumulate here in the middle of the body, where at the region of the heart, mostly at the thoracic vena cava. And since we increase the blood in the thoracic vena cava, means that we increase the blood volume in it, and so it increases the central venous pressure. See, it's about understanding them, okay? Just don't skip them like I did. Arteriole dilation, okay? Now, as I said, we have arteries, and in arteries, at the end, we have arterioles, and from arterioles, we have capillaries, and then we have veins. If we dilate these arterioles, this means the blood can move from them in very big flow, and so it will reach the veins, and this increase the blood volume in the thoracic vena cava, which will increase the central venous pressure. Simple. Now we have muscle contraction of the limbs, because mostly, if this is your leg, and this is a vein in it, once you move, the muscles will contract and they will push, they will constrict the vein, and so the blood will move in the vein up to the heart. And what is close to the heart? The thoracic vena cava. And so it will increase the central venous pressure. And finally, arterial constriction will reduce the thoracic vena cava blood pressure, and it will decrease the CVP, which is opposite to what I said. We said the heart, near it, there is thoracic vena cava, and in arteriole, if we constrict them, blood can't move in them, and so this decreases the blood in the veins. And once the blood decreases in the veins, this decreases the blood volume in the thoracic vena cava, which decreases CVP. I know this is a lot, but please, guys, just understand them. I want to review them, wallah. I want to review this slide again because I know it's very important. But for the sake of time, just understand them. Okay. Now let's talk about something called Wind-Kissel effect, okay? And it's very important. You will probably have a question about it. Now we finished the veins. Khalas, alhamdulillah, we are not talking about veins anymore. Now we are talking about arteries. And this Wind-Kissel effect, it's about the aorta. So in aorta, you took it in histo, we have the lumen, we have endothelium and these things, but in the middle we have elastin. And elastin causes recoilation. So once we put blood in it, it will expand and then it will recoil in very strong way that will push blood forward. And that's exactly what Wind-Kissel effect means. We have here the left ventricle, and it's connected to the aorta. Once the left ventricle contracts, the blood will be pushed into the aorta and the aorta will expand. Okay? And once the aorta expands, the blood will not know where to go. Should it go forward? There is no valves in the aorta. And so the blood will not know, shall I go here? Or shall I go like this? Or shall I go like this? The blood is in a complete loss because the aorta expanded. So the blood can't know where to move, and there's no valves. But because the aorta have the elastic recoilation, after it expands, it will recoil very heavily. And this recoilation very heavily will push the blood forward. And that can be seen in this picture. Once the left ventricle contracts, the blood will move, the aorta will expand, but the blood can't know where to go, okay? But once the elastic recoilation works, so the aorta recoils back, the blood will move forward in one manner, in one direction. And that's the Wind-Kissel effect. Wind-Kissel effect is very important. Wind-Kissel effect is basically, the aorta, elastic recoilation of aorta will make the blood move in one direction. Okay, that's exactly it. And so Wind-Kissel effect is very important because it will direct the blood to move in one direction. And so it keeps the blood moving in one direction during the ventricular systole. And this is the explanation of whatever I explained. It's no need to know this word by word, just understand the phenomena. Like left ventricular contraction will cause aorta to expand, blood will not know where to go, then elastic recoil of the aorta will push the blood forward, and that's it. That's the Wind-Kissel effect. Now let's talk about pulse pressure and mean arterial pressure, and it's simple. We have systole and diastole in our ventricle, and we have pulses. You probably took that before, and it's not the first time to take pulse pressure here. And so once you have the ventricular systole, you will have a pulse pressure of 120, mostly, and that's the normal. And you will have at diastole a pulse pressure of 80, okay, which is diastolic pulse pressure. And so the pulse pressure mainly, generally, it's the systolic pulse minus the diastolic pulse. So assuming I have systolic pulse of 120 and I have diastolic pulse of 80, يعني diastolic pulse pressure, I will have the pulse pressure total, يعني is the difference between them, which is 40. Okay, this is the pulse pressure. The pulse pressure is the difference between the systolic pulse and the diastolic pulse pressure. Okay, or يعني systolic pressure minus diastolic pressure. You know, when the ventricles contract, they have a pressure, and so this is the systolic pressure, let's say 130, and when they expand, they have a diastolic pressure, let's say 60, and so minus these from these, you will have the pulse pressure. Okay, but that's the pulse pressure for one pulse. Okay, from one pulse we have systole, diastole, minus them we have one pulse pressure. Now I want the mean arterial pulse pressure for all the pulses. It's the diastolic pressure, يعني the 60, let's say, plus third of the pulse pressure. يعني how to, I don't think he will ask you, to calculate it, but يعني assuming you have 70 as diastolic pressure and 100 as systolic pressure. Hello? Now the pulse pressure is 100 minus 70, which is 30. Okay? Now this is for one pulse. The mean pulse pressure is not in between the diastolic and systolic, because we are most of the time in the diastolic phase and like 1 or 2 seconds in the systolic phase. So it doesn't make sense for the mean to be in between. No, it should be near the diastolic more. And so that's why we take only third, not half or more. Okay? And so what is the mean arterial pressure? It is the diastolic pressure, which is 70, plus third of the pulse pressure. The pulse pressure is 30, so we take third of it, which is 10. And so 70 plus 10 equals 80, and that's all. That's how we calculate it. You take the diastolic pressure and third of the pulse pressure. Okay, that's it. So here you can see, this is the diastolic pressure, this is the systolic pressure. The difference between them is 40, and that's the pulse pressure. But the mean is not here in the middle. No, it's more into the diastolic, because we are in the diastolic phase most of the times. And since it's here, it's the diastolic, the 80, plus third of the third of the pulse pressure, which is third of 40. And you will have this value. That's how you calculate the mean. Now, this part, yani most of it is math. I'm not sure if he will ask you about it, but this part, yani you will definitely have a question about it. So let's focus. We have abnormal pulse pressures. Normally, we have this heart and this aorta, and this left ventricle is pumping into this aorta, and we have a specific pulse pressure, let's say 40. Hello? This pulse pressure is from the ventricular contraction into the aorta. Okay? If anything happened in this, the pulse pressure will change. Hello? So the left ventricle, and this is the aorta. Left ventricle is contracting. The aorta is, yani, let's say, expanding at the beginning, and it will, the blood will go through it. Okay? That's the normal thing. And so we have this normal pulse pressure. The diastolic is 80. The systolic is 120. Now, in one case, we have sclerosis. And in arteriosclerosis, the blood vessel will be full of these plaques, and so it will be narrow. And so when the left ventricle will contract, yani, it needs to contract in very big, let's say, pressure in order to move the blood through these plaques, okay? And since it needs to contract with a very blood pressure, you can see the systolic, how much it increased. It increased from this 120 into this, which is 160. The diastolic have no changes. It will diastole normally because the blood will move at the end. But since it needed a very big pressure to move the blood, this will increase the systolic only. And so once you see this graph, this very big graph with a very big pressure, this means that we have arteriolosclerosis. Now, the second one is aortic valve stenosis. And so we have the left ventricle, and here we have the aortic valve. The left ventricle will contract, the blood will move through the aortic valve. Now, assuming we have aortic valve stenosis, this means this aortic valve is mostly closed or blocked. So the left ventricle needs to contract with a very big amount of pressure to move the blood through it, but most of the time it can't move the blood from it very much. And so this blood will revert back. And so even if the ventricle contracted, this contraction is for nothing because blood can't move in it. So even if we have very big contraction, the blood didn't move. And so you see, this is the normal, let's say, pulse pressure. And in arteriolosclerosis, we have very big increase. But because the blood moved, because in aortic stenosis, the blood didn't move. The heart contracted, but the blood didn't move. And so the heart can't contract anymore because the blood is not moving. And so even this normal blood pressure, it will decrease. You see, it decreased. Why it decreased? Because the heart contracted, the blood didn't move, and so the heart can't contract. It's meaningless. Why am I contracting? And so the pressure of the systole decrease. But that's not all. Since the blood reverted back, the diastole can't be fully expanded because we are putting blood in it. So it can't refill because it is refilling from another side too. And so the diastolic blood pressure will increase too. And this means that if we have this normal pulse pressure, it will decrease from here and from there. The systole will decrease because the blood can't be moved. And so it will be like this, it decreased. And the diastolic will increase because the blood is reverting back into it. And so we will have it like this. So it is getting narrower from both sides. Okay, it's like compressing the graph. You see the graph here and here? It's like we compressed it like this. And this is important because he just may put this graph and like, what is this disease? And you must answer. And since we are compressing it, this is decreasing the difference between the pressures, and this will decrease the pulse pressure. So for the last time, I know I talked a lot about this thing, but because it's very, very high yield, normally pulse pressure is the difference between systole and diastole. If we have arteriolosclerosis, we need a very big pressure to move the blood. And so the systole will increase very much, but the diastole is the same. And so the difference between them will increase. And so this will increase pulse pressure. However, if we have aortic stenosis, the systole will decrease, the systolic blood pressure will decrease because blood can't be moved, and the diastolic blood pressure will increase. And so the difference between them will decrease. And so we have decreased blood pressure because it's getting narrower. So if someone had normal blood pressure and it increased, that's directly atherosclerosis or arteriolosclerosis. If we have pulse pressure decreased, this is aortic stenosis directly. Okay? I hope it's clear, and that's the concept till here. Now we are starting a new. I know there is so many hectic concepts, so I want you to understand them all, please. So which pressure? Now we are talking about blood pressure and the heart pressure, heart chambers pressures, like the pressure in the right atrium, pressure of the right ventricle, and these things. But how did we know these pressures, Yani? How can you know a pressure of a right atrium? It's weird because we use this. Look, we have this this thing which has a balloon at the end of it. Okay, and this thing, this is the heart. Okay, and we have, let's say, right atrium, right ventricle, left atrium, left ventricle. And now we are using this thing and we are entering the right atrium at the beginning. And so since we are entering the right atrium, this thing will give us a read of the right atrial pressure, let's say. Then we can continue and it will enter the right ventricle and it will give us the reading of the right ventricle. But then it will not go directly to the left atrium. It will go to the pulmonary artery because we will go to the pulmonary circulation, lung وهدول. And so this thing will go through the pulmonary artery and it will give us the pulmonary artery pressure. By the way, the thing is like this. Pulmonary artery pressure. But after we reach the pulmonary artery, if we continued anymore, we will not reach the left atrium. We will reach the lung and we will pierce the lung. We entered the right atrium, right ventricle, then pulmonary artery. That will not end with the left atrium. This will end with the lungs. And we can't go to the lungs because if we went to the lungs, we will pierce it most of the time. And that's the function of this balloon. We will inflate the balloon. And so this is pulmonary artery. If we inflated the balloon, it will block it. And so there is no moving of blood here anymore. And so this reading of this place is the same of this place, same of this place, same of the left atrium, same of the left ventricle, because there is no blood movement anymore after this balloon inflation. this place, all of it, there is no blood movement. So this place have the same reading of this place, of this place, of the left atrium, of the left, not the left ventricle. The left ventricle has a completely different thing, but yani at least till the left atrium. And so it will give us this wedge shape reading, and this wedge shape reading is the left atrium pressure. Okay, so wedge pressure. To determine the pressure in the right heart, yani right atrium, right ventricle, just put the catheter, who this thing, this thing, it's catheter. Just put the catheter directly into them. Okay, which pressure is used to know the left atrium pressure? Okay, how do we do it? We put the catheter in the right atrium, then right ventricle, then pulmonary artery. So if we continued, you will reach the lung. So we will just inflate the balloon, and so every reading after that till the left atrium, not the left ventricle, it's a different story. Every reading till the left atrium is the same. And so the reading here will be yani, the reading of the left atrium, which is with this wedge shaped thing. So this is the reading of right atrium, which is the beginning, then right ventricle, then pulmonary artery, then we inflate the balloon. Everything after it, it has one reading, which is wedge shaped reading, this wedge shaped thing. Now, this technique, this whole thing is just to know the pressure of the left atrium. And how much is it? It is 8 till 12. Okay, please memorize it. It's 8 till 12. Okay, the wedge shape, يعني اللي هو left atrium pressure is 8 till 12. Now, why is that important? Why would we care about the left atrium pressure? Because of two things. First thing is mitral valve stenosis. The other one is congestive heart failure. What does that mean? Now we have the left atrium and left ventricle, and between them we have mitral valve. Okay, here we have mitral valve. If we have mitral valve stenosis, it will be blocked, and blood can't move from left atrium to left ventricle, and so blood will accumulate here, and it will increase the left atrial pressure. And so this wedge-shaped thing will turn like this. And once we see this, خلاص, we know we have mitral stenosis mostly, okay? And so this thing is used to diagnose mitral stenosis because this wedge-shaped thing will be so big, which means that blood is accumulating, which means that we have mitral stenosis. Another thing that if we have congestive heart failure means that in heart failure, the left ventricle can't pump blood. يعني خلاص, it can't pump, it's just there, staring at everything. It can't pump anything. And so blood will accumulate and it will revert back to the left atrium, which will also change the wedge shape into this big shape, which means we have congestive heart failure. You don't need to know يعني when it is congestive heart failure and when it's mitral stenosis. خلاص, just know that we use this catheter thing, the wedge shape pressure, into diagnosing two diseases. The first one is mitral stenosis, the second one in congestive heart failure. Why? I explain to you why. But there's no need to know when it is mitral stenosis and when it's congestive heart failure. No, there is no need for that. Now we have a question. This is a very big question. He said he will not ask you about it, but just for the sake of safety, I will explain it. So you have cardiac outputs, you have mean pulmonary pressure, we have right atrial pressure, and we have pulmonary wedge pressure. And pulmonary wedge pressure is the left atrial pressure. And he wants you to, he wants you to have the pulmonary vascular resistance. You just memorize it, for the sake of safety. Vascular resistance of the pulmonary is the difference of pressure over the cardiac output. And it's difference of pressure of what? Since it's pulmonary, okay? It's from the pulmonary artery and the left atrium. And the pulmonary artery, we have it here. Where is it? Yeah, mean pulmonary artery is 14. So we put 14 minus. Where is the left atrium? It's the wedge pressure, which is 8. 14 minus 8 over the cardiac output, 4. It will be 6 over 4. It will be 1.5. So to know the vascular resistance, it's the difference of pressure over the cardiac output. Difference of pressure of what? He wants pulmonary. So we start with pulmonary. Pulmonary artery. What's coming after it? The left atrium, which is the wedge pressure. Minus them, we have the difference of pressure over the cardiac output. We have 1.5. That's pretty much it. Okay, now this is a checkpoint. If it was a live record, live session, if you guys have questions, you can ask me. Since this is a recording, I recommend you to have a break. ممكن open the slides, review them, because يعني we discussed so many things so far, and whatever is coming next, it's not related at all to whatever we discussed. Okay, so have a break, breathe, and يعني I will continue. Okay, now we have transcapillary fluid exchange, and this is a very big important concept. So we have the arteries. Okay, this is an artery, and at the end of it, we have the capillaries, and after the capillaries, we have the veins. Hello? Now, these are the capillaries. When blood moves through them, the blood can get out, and it can get filtered out, okay? And it can be reabsorbed, because this is the special thing about capillaries. They can filter blood out because they have very big permeability, and sometimes they can reabsorb, okay? And so, يعني there are four forces, يعني four type of forces, which is called the Starling forces that determine the net movement of fluid across capillary wall. يعني this is capillary and blood is moving through them. There are four forces affecting this capillary, maybe from out, maybe from inside, that will cause this blood maybe to get out, maybe to stay inside. يعني these forces are playing very big role in the blood movement in the capillary. Now, what are these four forces? There are pushing forces and pulling forces. A push force means that this is the thing and it is pushing blood away from it. Okay, so assuming this is the capillary and there is something inside it and it has a pushing force, it means that it is pushing the blood out of the capillary. If this thing is out of the capillary, it is pushing the blood in. So pushing means it's يعني moving it away from it. Okay, that's pushing forces. And pushing forces are two forces: capillary hydrostatic pressure and interstitial hydrostatic pressure. هلا خلاص, you just يعني know by now. Pushing force is the hydrostatic pressure. Okay, يعني any pushing force is a hydrostatic pressure. It can be capillary, it can be interstitial. What's the difference? In capillary hydrostatic pressure, this means the thing is inside the capillary and it's moving it away. So it's moving it out of the capillary, okay? So capillary hydrostatic pressure, it's a pressure to move things outwards, okay? Interstitial hydrostatic pressure is something out of the capillary and it's moving it into the capillary, okay? So it's caused reabsorption. So in a blood vessel, we have two types of pushing forces, يعني hydrostatic pressure. One of them is capillary hydrostatic pressure, which move things outward. And we have interstitial hydrostatic pressure, which move things inward, okay? And so these are the pushing forces. Something is pushing outside and something is pushing inside. The outside one is, يعني the one pushing outside is the capillary pushing force. The one pushing inside is the interstitial pushing force. Now we have pulling forces, and pulling forces are made by proteins, okay? يعني osmotic means protein, okay? Osmotic means it's made by protein. And so pulling forces are pulling the things into it. So if it's out, it's pulling the thing out. If it's in, it's pulling the thing in, okay? These are pulling forces. And so we have two types of pulling forces: capillary colloid osmotic pressure, or capillary pulling force, and it's something inside the capillary and pushing the blood or pulling the blood into the capillary, okay? And it's pulling it into it. And the other one is interstitial pressure, interstitial colloid osmotic pressure, and something outside the capillary and pulling the blood into it. So it's pulling the blood outward, okay? So to summarize whatever I said, we have, to summarize the thing, there are things that push things outward, which is the capillary pushing force. This push things outward. And the another one that pull things outward also is the interstitial ocnotic colloid pressure. These things push or pull things outward. And so they will increase the filtration. Yeah, they will increase the amount of things getting out of the blood. The another two are the pulmonary, what's called? The first, the another two are things that make things go inward, okay? And the first one is the interstitial pressure. And so it is interstitial pushing force. It will push things inward. And the another one is the colloid in the capillary, which will pull things inward, okay? I hope this is clear. I know it's a little bit messy, but once we have the formula, we will know what we are talking about. It's this minus this, okay? The capillary minus the interstitial. minus the pulling forces, which are the also capillary minus interstitial. We minus them. يعني خلاص, you don't need to understand, oh, this is pushing in, this is pushing out, oh, this way of explaining. لا خلاص, you just apply to the formula and you know the answer. Pushing forces are the things that are pushing. So one of them is pushing out, which is the capillary, and one of them is pushing in, which is the interstitial. We minus them and we see the total of pushing forces. Okay, then we minus it from the things that are pulling. One of them is pulling in and the other one is pulling out. And so the one in the capillary is pulling out, and the one in the interstitium is the one in the capillary is pulling in, and the one in the interstitium is pulling out. And so together we minus them, and so we have the this one, which is the pulling forces. And so we minus them and we see the direction. Since this is positive and this is negative, if we minus them, if it's positive, this means it's filtration, because this means that the push force, which is pushing out, is higher. If it's negative, this means the pulling force inward is higher, and it's reabsorption. So I hope this is clear. This is the actual formula, the one I'm explaining. So please follow this. Don't follow whatever is in Dr. Simon's slide, because I hate that formula so much. And so forget about the KF. You will get it in renal. It's a factor that it's important. But for the final time, the amount of or the net driving force is the pushing forces, which is the PC minus PI, which is the thing that are pushing. We minus them together and we have the pushing force. And so minus the pulling forces, like the capillary pulling force minus the interstitial pulling force. And so we have the pulling forces minus each other. If it's positive, this means the pushing is more because it's positive. This means we have filtration. If it's negative, this means the pulling is more, and so we have reabsorption. I hope this was clear. Now, this is also explaining the net driving force, but with a very important concept. I know this is becoming heavy, but just bear with me. We are finishing. It's 3 more slides. Inshallah, we finished. Now we have the fluid movement in the capillaries. Now, this is the blood moving in the capillaries. We have pushing, pulling forces, and whatever. Just know this, يعني memorize it, okay? Everything, يعني خلاص, from now on in cardio, everything in the interstitium is 0. يعني the pushing force in the interstitium is 0. No need to memorize it. The pulling force in the interstitium is also 0. So there is no need to focus on it at all. So you see the formula of this, which was the pushing force minus the pulling force. Anything in the interstitium is 0 in it, okay? So the pushing force in the interstitium is 0, the pulling force in the interstitium is 0, okay? Now what is left? What is left is the pushing force of the capillary and the pulling force also of the capillary. And so one of them is pushing out, one of them is pulling in, okay, from the capillary. So you need to know one last thing before we explain this thing, is that the capillary pushing force can change through the artery. So this is an artery, or okay, or a capillary, let's say. This is, a capillary. And so the this is the arterial end, this is the venous end. Near the arterial end, the capillary pushing force is so high, but at the end, at the venous end, it's very low, okay? But the oknotic pulling force, it's the same through all the capillary. So if you know that something is high at the beginning and low at the end, and something is constant all the time, what does that mean? This means here, if we apply the formula, the pushing force is higher, and so it's positive. At the middle, since the pushing force is decreasing, it will become, the difference between them will become 0. And at the end, the pushing force will be too low, but the pulling force is too high. And so at the end, we will have reabsorption, okay, which is negative. And so at the beginning, we have pushing, which is filtration. At the end, we have pulling, which is reabsorption. But you must know that the pushing is way higher than the pulling at the end. Yani at the beginning, let's say we pushed or filtered 10. At the end, we can, let's say, reabsorb 8. And so the pushing or the filtration is all the time higher than the reabsorption. And so at the end, we will have filtration of 2. Okay, not all the time 2, but at the end, we will have filtration. Okay, now, I hope this was clear. So at the beginning of the capillary, the pushing force is too high and the pulling force is constant all the time. And since it's too high, we will have filtration. At the end, the pushing force will be too low, and so the pulling force is higher, and it will pull things into the capillary. And so we have pushing at the beginning, we have pulling at the end, but most of the time pushing is higher, so maybe 10 and here 8. And so we will have 2 volume being 2 liter or 2 milliliter, let's say, being filtered. Okay, now it is filtered out of the capillary. Where will it go? It will go to the interstitium, and so we will have 2 liters moving in the interstitium, and at the end the lymph will take them. Okay, the lymph will take these 2 and yani move. Okay, it will move them to somewhere. Okay, and so in the capillary we have pushing forces that will make the blood, or yani some of the blood will get out, and this whatever got out, it will be absorbed by the lymph and it will move in the lymph. Now, what's the issue with this? Now we have some volume that got out, okay? And the lymph will take them. The issue is the lymph have some يعني maximum maximum capacity. So if we put 2, يعني if we filter 2, the lymph will take them easy. But let's say the capacity of the lymph is 10 and we filtered 11. The 10 will move, but one here will stay and it will cause edema. So edema is caused by increasing the blood that it's filtered into the interstitium. It can increase by several ways, okay? One of them is by inhibiting the lymph reabsorption. If we inhibited the lymph reabsorption, or it reached its maximal capacity, or there is lymph obstruction, the blood will stay in the interstitium and it will cause edema. Okay, it's not blood, by the way, it's transudate, مش بس blood, something else, بس I'm explaining generally. Okay, that's one reason. Now, what are other reasons? Didn't I say that there is a pushing force? Now, if we increase this pushing force, this will increase the amount of blood in the interstitium, which will make it very high to the lymph to take them, and so it will cause also edema. So one cause is lymph obstruction. Okay, another cause is increasing pushing forces, pushing from the capillary. Another thing, what is against the pushing force is the pulling force. And so if we inhibited the pulling force, if we decreased it by decreasing proteins or whatever, if we decrease the pulling force, this will make the pushing force dominating, and so it will push more blood out and it will cause edema. Last thing, we have one thing that we said that it's 0 all the time, which is the pulling force in the interstitium. It's the pulling force in the interstitium. It pulls things out of the capillary. Now it's 0 most of the time, but what happens if we increased it? If we make it 5 or 6 or whatever, it will pull blood out, and so it will cause edema. So we have 4 causes of edema. The first one is lymphatic obstruction, because lymph can't take blood, it will stay in the interstitium, and so it will cause blood to stay and it will cause edema. Another one is increasing the pushing force of the capillary, and if we increased it, this will make more blood go to the interstitium and it will cause edema. Another one is decreasing the pulling force of the capillary, and if we decreased it, this will make the pushing force of the capillary dominating and it will cause edema. And last thing is a pulling force in the interstitium. It moves blood out of the capillary, it pull them out. It's usually 0, but if we increase it to 5 or 10, it will pull blood out and it will cause edema. These are the 4 things that cause edema. So what is edema? Edema is accumulation of fluid in the interstitium. We have blood vessel and we have lymph. Here we have interstitium. If this blood accumulated here, we have edema. Why would we have edema? Due to high filtration, high blood getting out, which is increasing pushing force. Low reabsorption, here low reabsorption means low pulling force. And so if we decrease the pulling force of the capillary, we will have low reabsorption, and so more fluid will be here. And last thing is lymph dysfunction, and so lymphatic dysfunction here. Lymph can't reabsorb, and so the blood will stay in the interstitium, causing edema. By the way, edema is 2 types. First one is exudate, and the exudate has some protein in it, and it's not related to this at all. It's like if there is an insect bite you, or there is specific disease or inflammation, you will have protein infiltration. But the one we are talking about is the normal edema, which is just the blood getting out. There is no protein or anything, and it's called transudate. There is no protein, nothing weird in them. It's just the blood getting out. It's transudate, and it's fluid in the interstitial place. It might go to the leg, it might be bilateral, means both sides, unilateral, one side. It might be in the lung, so it's pulmonary edema. So these are the type of edema. But mainly edema is accumulation of fluid. Now, what causes edema? We already talked about this. It's either decreasing arteriole resistance. So this is the arteriole. If we decrease the resistance, means that we have very high pushing force, and so the blood will get out, which means increasing pushing force, we have high filtration. Other one is increasing venous return. So this is the heart. If we increased venous return, this will increase the pressure of the blood, which will increase the pushing force. And increasing the pushing force will increase filtration, which will cause edema. Decreasing plasma proteins, and plasma proteins are the one responsible for the pulling force of the capillary. If we decrease them, there will be no pulling force. And so there is no pulling force, domination of the pushing force, which will cause decreased reabsorption, edema, and finally decreased lymphatic drainage, اللي هو lymphatic obstruction, which will cause also edema. Final thing, I promise, it's just clinical application. It's literally nothing new, just how to apply all this info into diseases. And I will go through it briefly. It's very, very easy, okay? First disease we have is right heart failure. Okay, let me zoom in. So we have right heart failure. So this right heart can't push blood. Since we have a right heart failure, it can't push blood. Blood will accumulate. It will stay here. Then where it will go? It will go back to the veins. Okay, thoracic vein, leg veins, whatever. It will go back to the veins. And since we have increased the amount of blood in these veins, we are increasing the pushing force. And if we increase the pushing force, this will cause blood to get out, and it will cause edema. Where is this edema? In the periphery, in the veins of the legs, in the hands, and so it will cause peripheral edema. So right heart failure causes peripheral edema. Why? Because blood will accumulate in the veins, it will increase the pushing force, it will cause edema. Now we have left heart failure, and in left heart failure, this is the left heart, it can't pump blood. The blood will accumulate and it will go to the lungs. Okay, it will not go to the limbs or the periphery, it will go to the lungs, and it will increase the pushing forces, which will cause the blood to get out, and it will cause edema. But where is this edema? In the lung. So what we call it, pulmonary edema. So right heart failure, it will go to the limbs and periphery, and it will cause peripheral edema. Left heart failure, it will cause the blood to revert back to the lungs, it will cause pulmonary edema. Now we have the lymphatic obstruction we already talked about. If we have lymphatic obstruction, it can't reabsorb whatever is in the interstitium. It will cause the blood to accumulate in the interstitium, causing peripheral edema, because the lymph is at the periphery. Now we have liver failure or kidney disease. One thing you must know, that liver and kidney are responsible for protein formation, okay? And so if we have liver failure or kidney disease, we will have no protein formation, which will decrease protein. And what we say about protein, if they decreased, it will decrease the pulling forces of the capillary. And if we decrease the pulling force of the capillary, it will dominate the pushing forces, which will also cause edema. And it's peripheral edema because protein is in all the body, even in the periphery. Now we have inflammation, and once we have inflammation, the blood vessel, the endothelium of it will be destroyed, and so blood will move out easier. And so this will increase the pushing forces, and once we increase the pushing forces, blood will get out. Not just that in inflammation, but that's also important. But the most important thing, it's a weird phenomena in inflammation. This is the blood vessel, and we destroyed the endothelium. صح, blood will get out and we have increased pushing force, but that's not significant. What is significant, that there is protein here, there is protein in the blood. These proteins will get out, صح? And what does proteins cause? Pulling forces. And since they are out, they will pull things out, and they will cause peripheral edema. I hope you understand this, because I remember being asked about this. You have endothelium distraction, and so the blood will get out. Blood will have protein in it because there is distraction here. It's not filtration. There is no endothelium anymore. The blood will get out with its protein, and protein will cause pulling forces to out, and so it will cause peripheral edema. Guys, please memorize the symbols. This is the pushing forces of the capillary. This is the pushing forces of the interstitium. This is the pulling force of the capillary, and this is the pulling force of the interstitium. Okay, and memorize their name, like this capillary hydrostatic pressure, this interstitium hydrostatic pressure, this capillary colloid osmotic pressure, this is interstitial colloid osmotic pressure. يعني memorize the names. I'm not using them to make things complicated because the names I hate them. بس يعني memorize them. Okay. Now last thing خلاص إن شاء الله is dehydration. And once you are dehydrated, يعني look, this is the amount of blood you have. Okay, this is blood, and there is protein in this blood. This protein concentration is low because there is high blood volume. Once you are dehydrated, the blood volume will decrease, but the protein will not decrease. يعني blood volume will decrease لأنه you don't have fluid, but the protein level will be the same, which will increase the protein's level, which will increase their concentration. And once you have in the capillary high protein concentration, this will increase the pulling force of the capillary. So they are pulling them into the capillary, which will increase the reabsorption, which will maintain the blood pressure. Okay, so final thing is we have a blood vessel, we have protein in it. Once we are dehydrated, the protein concentration will increase because we have less fluid. And since protein concentration increase, it will increase the blood pulling force into the capillary, which will increase reabsorption, which maintain the blood pressure. These things are very important because you will mostly get asked. Now questions. 35-year-old woman visits her family. She has her main artery, يعني this big, very big, let's say, case. Which of sets of changes would be expected in this patient? And what is this patient has? It has aortic valve stenosis. Okay, what do we say about aortic valve stenosis? This is the normal, and in aortic valve stenosis, it gets narrower. So it becomes like this. يعني the pulse pressure, what will happen to the pulse pressure? It decreased, right? So first thing, it must decrease. The stroke volume, the amount of blood we are pushing, we said we can't push a lot of blood because there is stenosis, so the blood will revert back, so it will also decrease. And so we have also systolic pressure. The systolic pressure, it gets narrower. It decreased also because of the blood reverting وهيك. So the answer is E. So what happened in aortic valve stenosis? The pulse pressure will decrease because it's getting narrower. The stroke volume will decrease because we can't push blood. And the systolic pressure will also decrease because يعني blood is reverting. We can't أصلاً move blood. Here, you remember this graph. خلاص, this graph of pressure versus volume of the compliance. Which are the physiological change that will change curve 2 to curve 1. هلا we know curve 2 has low compliance. Curve 1 has high compliance. حلو? Now, what changes will change curve 2 to curve 1? يعني which change will increase the compliance? Hemorrhage, this is not related. Normal aging, it will cause calcification, it will decrease the compliance. Reduced venous tone, this means that we have a vein and we caused vasodilation, not vasoconstriction, reduced. So vasodilation, which means that the vein is relaxing, it's expanding, it increased the compliance. So the answer is C, because we want to increase the compliance, and this is the only choice that increases the compliance. Now, last question, which of the following statements about sympathetic stimulation is accurate? Yani, what about sympathetic nervous system is accurate? And if we noticed what's called E, we have venous reservoir vasoconstriction. We said that the veins are the reservoir in our body. And so if we constrict them, it will increase the cardiac output and venous return and these things. And how do we constrict them? By this sympathetic stimulation. So what is related to sympathetic stimulation? Venous reservoir vasoconstriction. So the answer is E. That's it. I hope you guys liked it. I hope I explained well. And if you have any question, this is my number, 05069240055. Please reach me whenever you want. Okay? Thank you.